formation or clot formation. And this is what's happening over here. So all these reasons are just lowering down the blood flow in portal vein. And then hypercoagulating state, so that's the state of the body itself where blood makes clot often. In infants, the cases of sepsis, umbilical vein catheterization, and acute dehydration can contribute to thrombosis. Clinical and lab data with portal vein thrombosis, patient might have abdominal pain, fever, leukocytosis, hypovolemia. Leukocytosis, if there is any kind of bacterial growth because of stasis, because if the flow gets slow, the chances that bacteria can grow somewhere or some growth can happen goes up too. So it is not like portal vein thrombosis always is going to give these clinical presentations to the patient, but the patient might get any of these presentations. Sono appearance with thrombosis. You all are at clinical site and many of you do DVT on regular basis. So I'm sure this is not new to you, that appearance of portal vein thrombosis, how the thrombosis look inside the vessel. So depending on the stage of the disease or disease progress, when the thrombus is fresh, it's anechoic, we just went over that. And when the thrombus stage 2, so we did talk about these two stages earlier, it becomes echogenic, and there is a dilatation of portal vein at the proximal to the thrombus or occlusion. Small collateral flow may be seen. Stage 3 in liver, there is another stage that we document often with portal vein thrombosis. It is called cavernous transformation of portal vein. Please know that. Worm-like vessels at porta hepatis that represent collateral formation. To understand cavernous transformation of portal vein, if I draw portal vein over here, and if there is a thrombus over here, the blood is not coming inside the liver normally, then portal vein is going to, because there is too much pressure from back here, sometimes the portal vein is going to make parallel channels to enter inside the liver, small collaterals to enter inside the liver, and those small collaterals are called cavernous transformation of portal vein, and this is often seen with portal vein thrombosis. So please know that these two go together. Somehow this is not seen with tumors, somehow this is not seen with others commonly, but with portal vein thrombosis, it is seen commonly. So know that these two terms go together. Numerous worm-like vessels at porta hepatis that represent collateral formation. Color Doppler may reveal absence of color wherever the thrombus is. This itself does not indicate occlusion. There may be a dropout of color due to angulation or decreased sensitivity to the flow. We already went over that concept in earlier slides. Thrombosis tumor must be visualized within the lumen in order to make the diagnosis. So we went over that too. So when you look at this image over here, you are not seeing any blood in any of the vessels, like major vessels. Over here, it's about the hepatic veins. So Oh, okay. It is not about the hepatic veins. The hepatic veins is over here. Somehow the veins are here, but what you are seeing, the main portal vein that is entering inside the liver, that does not have flow. Over here, main portal vein has little bit of the flow, then there is a missing flow everywhere else. So it's just tickle of the flow that's coming in. And then you see these parallel channels over here at the porta hepatis. That's called cavernous transformation of portal vein. This is typical when you take it in. When you look at this image, this is the typical of cavernous transformation. So you see something like this or something like this, that's a cavernous transformation. And then in 2D, you are going to see anechoic circles or anechoic vessels. When you use the color, you are going to see good amount of color with cavernous transformation. So all those were with thrombosis. The next part is hepatic surgery and liver congestion. So we will start talking about liver transplantation. Liver transplantation is the common process now, or common surgery nowadays, or we can call it common procedure. Orthotopic liver transplantation, recipient liver is removed and donor's liver is put in. It's performed to eliminate irreversible disease when more conservative medical or surgical treatments have failed. Mainly we talk about cirrhosis. Cirrhosis is also called end-stage liver disease. So if the patient has cirrhosis, there is no return. That's the time when liver transplantation is required. And cirrhosis mainly comes from over drinking. So that is why it is recommended that drinking is not good above moderate amount, because finally it can lead to the problem where the patient might need liver transplant. Common indication for transplant, cirrhosis comes on the top. Chronic hepatitis, inborn disorder of metabolism. And if you remember glycogen storage disease, that is one of those. Scoliosing cholangitis, so basically as you can simply call it cholangitis, when then Budd-Chiari syndrome, or unrespectable but local hepatoma. Unresectable, because you cannot take it out, but it is still there. So if you remember that there are different sections or segments of the liver, and when we talk about different segments of the liver, we say that it is possible to take one segment if any lesion or any cancer or any growth is affecting that segment. But if taking out that segment is not possible because of the size of the lesion or because of the coverage of that lesion, then liver transplant is another way to get rid of that or take care of it. If the portal vein is occluded or small in recipient, surgical anastomosis is not possible. So please know this part. The portal vein size is important, and if the portal vein is occluded or small in recipient, then anastomosis is not possible. With absent portal flow or any minimal amount of flow in the periportal collaterals, angiography is required to outline vascular anatomy of the recipient. Ultrasound is well suited to identify other complications such as IVC thrombosis, portal vein thrombosis, extrahepatic fluid collection, and living donor transplant, in which the portion of the healthy person's liver is removed. Living donor liver transplant is for pediatric recipients involves removal of approximately 20%. So living donor transplant for pediatric recipients. So when we are donating it to pediatric patient, then only 20% of the liver is required, not the entire liver is required for transplant. So that was the basic of liver transplant. And any question up to this point? From Budd-Chiari syndrome, portal vein thrombosis, and liver transplant. Any question? Okay, let's talk about portosystemic shunt. How many slides are left? Can we take just 5 minutes break? Just 5, and I'll be back at 1:50. Yes, no?
Yes.
Yes. Okay, 5. Just 5 minutes, and I'll be back at 1:50. And I'm not going to turn this off. I'll just mute myself.